Okay, hello everyone. Yeah, this is another video under the clinical psychology. So here we'll be looking at impulse control disorders. We're talking about ICDs. Okay, this is the third topic under the chapter. All right, so moving forward, we're going to be talking about three major categories under here too. We'll be talking about the diagnostic criteria. We'll be talking about the explanation of ICD, explanation in terms of causes. What are the causes of ICD? All right, and then lastly, we'll be looking at the treatment, how to treat ICD. Okay, so talking about the diagnostic criteria now, under that we look at symptom too. Okay, yeah, under the ICD 11, all right, it refers to repeated inability to resist. Okay, you have the inability, and it's not just once, inability to resist something, all right, a particular impulse or urge to perform a behavior. Okay, now, and there is often a short term reward associated to it. Okay, so behavior provides short term reward. So the action, the activity itself provides a short term reward. Okay, a feeling of excitement, relief, but can lead to long term negative consequence afterwards. Okay, we're going to talk about that and then you get to understand it better. Now, negative consequences is also associated to it. It can cause harm to yourself or to others. There can be distress about the behavior. Okay, when you practice it, it can lead to a form of distress, significant impairment in areas such as family or friendship or even work at large. So these are the things that can affect ICD, right? Yeah. Types of impulse control disorder. Number one, we have kleptomania. What is kleptomania? Can you see this image? The person is trying to steal. So what does that tell you? A disorder marked by a powerful or irresistible urge to steal items. Thieves are different, huh? Thieves actually plan to steal, right? Thieves plan to steal, but kleptomaniac patient, they do not necessarily plan to steal. All right, and the thing they are stealing is actually not the goal for them. It's the behavior. I don't know if you get it, but let me explain further. What I'm trying to say is, if a thief tries to steal, and for example, is unable to steal, he doesn't feel happy, right? Okay, but when he steals money now, he's happy because of the money because he knows he can do something with it, right? He can plan events, he can, build something, project, a lot of things, right? Now, however, for kleptomaniac patients, they can steal and eventually they won't use the thing. So it's actually the behavior for them. It is the behavior. So it is a powerful urge to steal. And then when they steal, they satisfy that urge. Okay? It's not what they steal that matter, it is the activity that matters. Now, key feature: intense tension or affective arousal before theft. All right? So feeling of excitement and gratification or relief during or immediately after the theft. Can you see that? Theft is not motivated by monetary gain. So here, all right, stealing here is not motivated by monetary gain. It's not the object, but it's the behavior. It's the gratification that comes with the activity. Now, diagnosis. For diagnosis, behavior must be better explained by another. Sorry, must not be better explained by another disorder, but rather better explained by another disorder, then it is not kleptomania. All right, it must not be explained by substance, it must not be explained by intellectual impairment. All right, if not, it will lead to another category. But excuse me, if all those things are out of it, then and the person still has this behavior, then it is kleptomania. The second one, we have pyromania. What is that? Look at the picture, the person trying to start fire. Okay, a disorder characterized by a compelling urge to set fires. Okay, yeah, I think a lot of children actually had that urge at some point. When you're being asked to go burn something, you're so happy, okay? And then when you're burning something, you don't want the fire to go out. You want to, I mean, these are things I also experienced while I was young, but it is not actually the same, okay? Now, this person has the urge to actually set fire For my situation, if I'm asked to do that, I feel a little happy, okay? But then I don't have the irresistible urge. I don't have the compelling urge. Now, key feature, strong prefer certain tension. You have this tension that is hard to resist, pleasure and excitement or gratification experienced during and immediately after fire setting. All right. Now, fascination with fire, a fascination or preoccupation with fire or fire related stimuli. So it can be for fire or stimuli that are related to fire. Okay. Watching fire or handling firefighter equipment, that can also be relevant to the urge this person feels. Okay. So there might not be clear motives. Anyway, no clear motives such as monetary gain, okay, sabotage or revenge. These are not exactly the points, the reason. No. If it's for revenge now, then it's a different situation. If it's for monetary gain, it's a different situation. If it's to sabotage things, it's a different situation. Now, behavior are not explained by another disorder as well. Okay, the third one now we have under this category is the gambling disorder. Gambling disorder is very, very serious, especially nowadays where there are a lot of betting sites, right? It can be very, very difficult to control. Okay, and another thing about gambling disorder is that it is very close to substance addictive disorder, because someone that is suffering from gambling disorder, it's a serious case. Okay, like the person might even spend all his savings and even still just to be able to fulfill the urge to gamble. All right, so you might wonder, when someone loses money, why does he keep going back to it? It's actually beyond either winning or losing money. Okay, it is the behavior for them. It is the behavior, it is the action, it is the activity. All right, the fact that they stand the chance to either win or lose, so they are positioned at a vantage point where they feel that, okay, yeah, I can either win or lose. So they already feel that satisfaction at that point. So whatever comes as the end result, either they win or lose, they still want to go back to that feeling of having the possibility of winning or possibility of losing. So the possibility of winning is what compels them to go each time. Okay. Now, a pattern of persistent or recurring gambling behavior, whether online or offline. All right. So there is impaired control, inability to control it. All right. Impaired control over gambling, e.g., duration, money spent. Okay. Yeah, you can take your time, you can take your money. Priority over other activity. Gambling takes priority over other important activities such as interest. Okay. Sorry, other activities and interest. It takes priority over every other thing. Continuation despite consequence. You see, all right. Continuation or escalation of gambling despite significant negative, like losing your money, you still go ahead and do it. You know that, okay, it's affecting your family, it's affecting your partner. All right, you still continue. Okay, distress and impairment lead to distress or impairment in major areas of functioning. Okay, for example, family, work, and relationship can actually affect relationship with those people. Now, measurement and assessment. How do we measure? We're talking about ICD. Well, the measurement for kleptomania was not discussed in this. For pyromania was not discussed. The measurement for pyromania was not discussed, but that of kleptomania was discussed, right? So I think they just try to reduce the content of the course book by focusing on one aspect alone. Okay, so they just focused on the kleptomania alone. Also, there was a study that they did on gambling disorder. All right, they didn't also mention a particular measurement for gambling disorder. However, what they did is they pick Y-box scale, okay, which is a measurement for obsessive compulsive OCD disorder, obsessive compulsive disorder, right? So they try to modify the Y-box scale to be able to measure gambling. All right. So that was what they did to measure gambling in a study we're going to see very soon. Okay. Now, this is the measurement of kleptomania, which is called KSAS, Kleptomania Symptom Assessment Scale. Now, overview, it is an 11 item. Keep that in mind. Okay, can you remember the BDI? How many items is it? Can you remember? Okay, it's 21. Okay, now this one, it's uh, an 11 item self-report. Okay, so sorry, I was lost in thought there. Okay, they're designed to measure impulses. Okay, impulse, that is the zeal, the passion, the thoughts, the feeling, and behavior related to stealing. Okay, now items are rated on a numerical scale, which is quantitative data, typically 0 to 4 or 0 to 5, reflecting symptom severity. Example of item includes if you had urge to steal during the past week. Can you see that? If you have urges to steal during the past week, so that measures the impulse, okay, or the feeling. No, it's the impulse rather. All right, it measures the impulse. If you had the urges, okay, on average, how strong were the urges, with options ranging from none to extreme. So it can cut across from 0 to 4 or 0 to 5, depending. Okay, now purpose provides a quantitative measure to aid in diagnosis. It helps clinicians track symptom severity over time and assess the effectiveness of intervention. So if you're able to track, you can use this when designing a study. Okay, if you also at some particular point want to start the therapy with someone, you can start with this, and then maybe after a few session into the therapy, you can even give this KSCS again. After the therapy, you can give the KSCS again. Maybe 6 months after that, you can still give to see the improvement level, right? Okay. Yeah, research method and issue. Okay, talking about the measurement. KSCS reliability. The KSCS has demonstrated good test-retest reliability. That is, when used over and over again, it produces similar result. Okay, if you give it to someone with kleptomania, it feels it, it produces a particular result. If you give it to the person again and again and again, the result is going to produce is similar. Okay, so what about concurrent validity? All right, concurrent validity means something having uh, relationship with a similar, let me say, a similar scale or a similar measurement. Okay, so the relationship now can be either positive or negative. Okay, so having a relationship. So now, if okay, now let's look at it. It shows strong concurrent validity when compared with another validated tool like the global assessment of functioning skill. Now, global assessment of functioning skill is to measure how you're able to function in the society. Okay, now if you're functioning very well positively, which can be like high score, all right, if you have high score here, which means you can function very well in the society, what are you supposed to score in the KSCS? Is it high or low? You're supposed to score high on the KSCS, which shows that you have high level of kleptomania, right? Okay, and then if you are not functioning properly in the society, you're supposed to have oh, sorry, I think I made a mistake there. If you're functioning very well in the society, which is high score in the global assessment scale, you're supposed to have a low score here, which shows that you do not have high level of kleptomania, right? You have high score here, you should have a low score here. But if you have a high score here, which means you have high level of kleptomania, then you should function less appropriately in the society. So that is the idea of concurrent validity. So they've been able to use that with this, and then they found out um, that inverse correlation, that concurrent validity between the two scale. Okay, so research method and issues, limitation of self-report. What are the issues? Reliance of self-report may lead to response bias, isn't it? Yes. What else can we talk about? Under-reporting. Individual might under-report symptom due to shame or embarrassment. Okay? Now, research method looking at issues now. We have nomothetic and idiographic approaches. Okay, what is nomothetic approach? It utilizes, now when we talk about nomothetic and idiographic, we are basically referring to quantitative and qualitative. Idiographic is more like qualitative. Nomothetic is like quantitative. All right. So now the fact that they used standardized assessments like the KSAS to gather large scale, all right, which increases generalizability data about common symptom and experience. Okay, they use the KSAS, which is a quantitative data, to gather a large scale of results, so that can gather a lot of data, right? A lot of information about the common symptom that an experience that can happen around kleptomania. So this, on the other hand, is more like a qualitative data, like case study, idiographic. Okay, so this recognizes that individual experience or impulse control disorder can vary greatly, right? So suggests that personalized assessment may be beneficial in understanding the unique manifestation of the disorder, right? Okay, so biological explanation, role of dopamine. Now, what is the explanation of impulse control disorder? We also have dopamine. We've been having dopamine in schizophrenia, in mood disorder now, also in the impulse control disorder. Now, how does dopamine help? Dopamine is the happy chemical, right? Yes. It's also the motivation chemical. Excuse me. Now, how does that relate to that? This is not depression, right? Yes, it's not. But when you feel down, you might want to feel, okay, yeah, I want to feel better. Then you go back to do, or let me say, you get yourself involved in the behavior again and again that makes you feel good. Don't forget, there is a feeling of uh, satisfaction that comes when you get involved with the stealing habit or setting fire or gambling. All right. So this is released in response to rewarding stimuli and enjoyable behavior. In disorder like kleptomania, stealing triggers dopamine release in the brain. So what about pyromania? When they start fire, setting their eyes on fire, on when they're able to touch other relating materials, the fuel, there's the trigger, it triggers dopamine release in the brain reward center. Okay, what about gambling? Gambling, okay, if you lose, yeah, there shouldn't be dopamine, right? But do not forget, according to studies, dopamine has already been released before the end result. So the anticipation part is the time where the dopamine is already triggered. So either you lose or not, dopamine will be released. So which means the person will still go back to it again. You see, right now, reward deficiency syndrome. Now, there's a concept here. When you begin to do the behavior over and over again, the amount of dopamine that is released now reduced. Okay, it's just the same way with those who take substance. Now, when they start with maybe a particular measurement, all right, you get to a point that their body gets adapted to it. They need more quantity of that thing to be able to trigger the same level of motivation or happiness. Okay, for example, someone taking maybe, I'm just going to use a drink of 1 liter. It will get to a certain point. Okay, 1 liter will produce 100% of happiness. Now, to get to a certain point that 1 liter will not be able to produce that 100 anymore. Okay, so the person will need up to 1.5 liter to be able to produce that 100% happiness. That is the reward deficiency syndrome. So with repeated compulsive behavior, dopamine level in the serotonin become reduced. So this deficiency now will necessitate the compulsive behavior. You will need more of that behavior, okay, as individual continuously seek dopamine to be high. Now, what is the side effect of synthetic dopamine? All right, treatment using synthetic dopamine, e.g., for Parkinson's disease, have been linked to emergency of ICD. Emergence of ICD. Okay, impulse control symptom like kleptomania, gambling disorder, or compulsive disorder. All right. Yeah, moving on from there, psychological explanation, behavioral perspective of the causes of ICD. We have number one to be operant conditioning. Okay? operant conditioning. What is operant conditioning? This is a reward system, positive reinforcement or negative reinforcement. But here we are looking at the positive reinforcement, the reward. Okay, behavior followed by a reward are more likely to be repeated. Is that so? Yeah, when you reward a behavior, there's a high tendency to want to repeat that behavior, right? Now, application to ICD. For example, a gambler wins occasionally, even if he doesn't win all the time, he wins occasionally. This serves as a reward and encourage continued gambling. Okay, even if you win once and then you lose 2 times, you might still feel like, oh yeah, but then I won once, all right, and then I stood a chance. Okay, so the thought of the winning now can encourage, according to the behavioral category, the psychological explanation, the reward now can trigger the behavior over and over again. Okay, now partial reinforcement. Now, this is the danger in gambling when it comes to the psychological explanation. There's a concept of partial reinforcement. Now, a constant reinforcement seems to be better compared to partial reinforcement. Why did I say that? Now, if you each time you perform a particular behavior, you know you always get, let's say for example, $100. Once you do something, you get $100. Once you do it again, you get $100. Okay, you might get to a certain point that okay, you're already certain that the reinforcement will come, right? So you only do it when you feel you'd really need the reward. You get a point. Okay, now for example, if I don't need the $100, I might just feel like, okay, yeah, since it's certain, let me do something else. Okay, let me do this, let me do that. Then eventually, when you need the reward, then you go back to it. Okay, when you don't need the reward, you can feel the need to do something else. Now, partial reinforcement, on the other hand, is to talk about the reinforcement can come today, it might not come tomorrow. When you do the behavior or when you do something, you might get rewarded. When you do it again, the reward might not come. When you do it again, the reward might come. When you do it again, it might come. When you do it again, it might not come. So the pattern at which the reward comes is unknown. Now that increases the thought over it. For example, if you gamble and every time you win, you might go to a certain point that, okay, what is the essence of gambling? Let me do something else, right? But when there is partial reinforcement, you begin to think that, oh, I don't know, maybe if I gamble now, that would be my chance. Okay? If I gamble now, that might be my time of winning. Oh, what if I lose this time and I didn't gamble? Oh, it might be that the next one I will do might be the one I will lose. So this one might be the one I will win. All right. So there is a possibility, there is a tendency. Let me say the zeal, the obsession that comes with unknown thing can be very, very addictive. Okay? Things that is not certain. Now it can be very, very, you can be very, very obsessed around it because you want to know, you want to see if this will be your winning game, if this will be your winning game. All right. So that is the partial reinforcement. Okay. The anticipation of a win, even after a loss, drives the compulsion to keep gambling. Okay, that, oh, this might be my time to win, even though you just lost. All right, you just lost. All right, this might be my time to win. Okay, let me go back to it again and again. Keep doing that. Okay, now the cognitive perspective. Now, according to Miller, he explained the concept of feeling state theory. Okay, which is explains the core concept of intense positive feeling, which is linked to a particular behavior. All right, so this is more like classical conditioning when you attach a feeling and a behavior together. According to Miller, which is the feeling state theory, each time you, okay, let me give this explanation. There are some there are some songs that when you listen to them, it reminds you of a particular emotion you had when you probably first listened to the song, right? Okay, there's a particular song that each time I listen to it, it reminds me of a particular mood when I was feeling sad about something. Okay, this can also be a danger. Sometimes I tell my students too, if you develop feelings for someone, all right, or maybe if someone is involved in a particular relationship, and during that time of relationship, there is a particular song you play often and often, you play over and over again, or you listen to that song a lot during that period. Now, even after the relationship, when you listen to the song again, it produces that emotion you had then. it brings about that emotion, okay, either the positive one or the negative one. All right, so now there are certain behavior that can also be linked to a particular feeling, okay, which is the concept of the feeling state theory. Now, feeling state mechanism encompasses sensations, emotions, thought, and psychological arousal. All right, so there is sensation around it, emotion, thought, and arousal. Now, fixation of feeling, intense feeling become fixated, okay, leading to compulsive behavior. Now, when that feeling is what you need, you want to feel sad, okay, you begin to play that song again. It reminds you of that emotion, okay? Or you want to feel good, you play that particular song again. It reminds you of that state when you're feeling good, right? Now, belief interaction, negative self-belief combine with positive event belief and loss of control belief. All right, now let me break this down. Negative self belief, okay? Now, when you combine that with positive event belief and loss, it can and loss of control belief. Wait, let me try to process that. What do I mean by that again? Okay. Yeah. This basically talks about when you have a negative belief about yourself, right? You have a negative belief about yourself. Okay, you're feeling sad right now, and then you want to feel good again, and you remember, okay, there is this particular behavior, we mentioned earlier that there is a feeling and the behavior linked together. Remember this particular behavior. Oh, each time I steal, right, each time I steal, I feel good, right? So there is that combination, so it makes you to go back into the stealing, which leads to lack of control now, okay. And then you lose the control over yourself, okay. So that is the idea here. Now, when you feel bad about yourself, you feel low and you want to feel good again, you go get yourself engaged in the behavior, all right, which is stealing or gambling, so that you can feel better. All right, so that also leads to negative thought again. You want to feel good again, you go do the behavior. So it's a cyclic pattern like that. All right, so moving forward, research method and evidence. Okay, objective. Brain imaging is actually objective. Sorry, yeah. Yeah, when you study the neurotransmitter, the dopamine level, okay, you can produce objective data such as the result from PET scan, MRI, fMRI, etc. All right. Now, what is the validity of those? Those methods provide high validity and reduce reliance on subjectivity, or let me say subjective self-report. Okay, when you try to measure by looking at dopamine and the likes, all right, they are mostly objective, okay, because the results produced by the scan, talking about your level of dopamine now, okay, they are often objective. Okay, what about research method and evidence? Okay, historical approach. Before modern imaging, research relied on post-mortem study. We spoke about that in the previous study I covered, okay, which means using the dead people, all right, and then you try to study their brain, okay, to be able to observe and look at the change, the difference between their brain and the normal people's brain. Okay, now issues and debates, individual versus situational. Biological approach, it emphasizes individual brain chemistry and neurobiological deficit, okay, which for example, the reward deficiency syndrome, okay. So this is a biological approach. Now, okay, yeah. So all those things now, it's individual brain chemistry, right? So this is an individual aspect. Now, the cognitive approach, rather, it's going to be more of the combination of individual and the situation, right? So considers how individual emotional state and cognitive processing. Cognitive processing is an individual thing about you, but then a particular behavior, okay, it interacts with situational influence. So there's a particular behavior you do in the environment, okay, so which interprets in your mind, or let me say that you interpret in your mind to be able to produce the thing. So basically, the cognitive aspect is a combination of individual and situation. So we can say that okay, cognitive tries to observe the role of situation and the interpretation of that situation by an individual, right? Biological rather focuses on individual alone. It doesn't look at the situational aspect. Integration, both the internal state, for example, dopamine imbalance, negative belief, and external trigger, e.g., rewards, okay, an upsetting event contributes to impulse control disorder. So it's a combination. All right. So looking at generalization versus individual variability, nomothetic approach. Okay, standardized imaging or assessment can help generalize finding, right? You can get objective data using this method, and then you can be able to cover a lot of people, a lot of data, providing generalized kind of data that can be used for everyone. So the level of dopamine now, you can be able to tell that, okay, this low level of dopamine, once you find it, you can generalize it. Okay, it's an approach that helps you to generalize the study over everybody. Idiographic rather is trying to tailor the um, the cause to a particular person, a personal situation. Okay, it reminds us that personal experience and subjective feeling vary, suggesting a need for tailored intervention. All right. So this is also a possibility around the cause of ICD. Now, what about the treatment? Okay. Now, nature of disorder. Impulse control disorder involves habitual compulsive behavior that individual finds immediately rewarding, right? But they have long-term negative consequence, e.g., harm to self, family, etc. Now, treatment approach includes both biological, which is drugs now, and psychological, which is CBT, cognitive behavior therapy. Okay, yeah, biological treatment. There is the use of opiate antagonist for gambling disorder. Now, what is the rationale and the mechanism for this? Opiate antagonists are drugs that traditionally used to treat substance abuse, right? You know, I said gambling disorder is kind of somehow related to substance abuse based on the level of severity. Okay, they work by blocking the brain's reward center. So instead of the brain reward system, center to be triggered when you actually practice such behavior, okay, it blocks it. The reward center will not be triggered. Excuse me. Now, reducing the reinforcing effect of addictive behavior, such as gambling. Example, we have norepinephrine reduce urge to gamble and extend period of abstinence. So this is one of the opiates, all right, and this is how it works: reduce the gambling disorder and the extends helps the person to be able to stay away from it. Okay, now let's look at the study by Grant et al. Okay, he looked at pathological gambling, okay, which is actually gambling, all right, can be treated with various methods, including psychological therapies, e.g., covert sensitization, imaginal sensitization, and drug therapy. Now, previous research by Kim et al. Showed that opiate antagonists can be effective in treating gambling, okay, though 10 to 30% of patients may not respond, all right. So that's the previous research. Now, the aim of this one is to identify clinical variables. If family history of alcoholism, intensity of gambling urges, okay? Yeah, to look at those variables that predict a positive response to opiate antagonist treatment. Now, if to see whether family history of alcoholism or intensity of gambling urges can actually be a variable that will help us predict if participants are going to respond to the treatment or not. Will this help us predict if participants will respond or it will not? Like, will there be a correlation between those that respond and their level of family history, or let me say the family history they had and their gambling urges they had? Now, let's look at the study itself. All right, so the design and method, they use two double-blind and then placebo-controlled clinical trial. All right. So double-blind, the experimenter, the participant do not know which condition they're in. It lasts between 16 to 18 weeks with 284 patients. All right. They used balanced gender distribution from the USA. Independent group design. So you either be in the drug or you belong to the placebo. All right. And then participants were randomly assigned to either the placebo or the several doses. Now we have the several doses of namorphine or naltrexone. Okay. You can check your the course book for more information on that. I didn't include that because of the excess detail. All right. So if I remember vividly, I think there is 50%. Okay. No, there is 50 ml, right? Dose, and there are different measurements of the namorphine to see maybe the higher the dose, the higher the result, or compare against the placebo. Now, main outcome measure, they use Yale Y-Ball scale. Okay, this is Yale Brown Obsessive Compulsive Scale. All right, they modify it to be pathological gambling scale. All right, so they try to convert the Y-Ball scale to measure gambling. All right, so to assess gambling urges, thoughts, and behavior over the past 7 days. Now, additional assessment includes scales of psychological functioning, anxiety, depression, and semi-structured interview for family history. Okay, especially related to alcoholism, to see if this will be a factor that will help, or let me see, they want to see the correlation between those with this history and then their level of response to the treatment. All right. So the result, treatment response. Treatment response was identified as at least 35% in gambling score for at least 1 month. Okay. So at least 1 month, if there is 35 reduction in the gambling urge, then it worked. So that is the operational definition. Now, what is the finding now? A family history of alcoholism was the strongest predictor of a positive response to opiate antagonist. Okay, those that respond to opiate, they are the ones that belong to the family, or let me say, they are the ones with family history of alcoholism. Okay, they are measuring gambling, but then they are still looking at this thing. All right. So they discovered that those that respond well to the opiates, talking about their gambling behavior, they are mostly the people with alcoholism. Do not forget that alcoholism also triggers the brain center reward, right? So now the opiate blocks the brain center reward. So if it blocks it, then that means there won't be reward in their brain system. So generally, this is what they discovered. Now, higher doses correlate with better outcome. So if you take higher doses of those opiates, there is higher outcome with strong gambling urges. Okay, so it was able to reduce the thing. Well, the higher the dose, the higher the improvement. Now, in the placebo group, younger age was associated with more positive symptom. All right, so younger age had more positive symptom, possibly due to less entrenched gambling behavior. So in the placebo, those with let me say that are advanced in age, they had higher symptom. Okay, the younger people had reduced symptom. Now, implication: genetic influences, that is family history of alcoholism, that is if they take alcohol a lot in their family, which can be genetically related, may predict who will benefit from opiate antagonist treatment and who will not benefit. Okay. Now, evaluation of the study by Grant et al. The strength, they used double-blind design, which is good, right? Minimizing researcher bias. This researcher does not know who took the opiate, who took the different levels of the opiate. Okay. Now, increasing the validity of the results. Quantitative data that was used to provide objective comparison of treatment, right, and its effectiveness. Now, ethical consideration. Ethical issue arise from using placebo, right, because they did not benefit, as participants may not receive active treatment. Now, when you do not treat people, you just use them in a study as a control group. At least at the end of the study, try to compensate by giving them the treatment as well. Okay, but if you do not mention the treatment, it will be what's the word now? It will be criticized. Okay, the study will be criticized. Okay, now, though informed consent clarifies the possibility of receiving a placebo, all right, so there was informed consent, however, initially that, okay, they might not receive, there's a possibility that they might either receive the opiate or the placebo. So if they receive the placebo, it's okay by them, right? And then they said yes. The participants agreed. Now, psychological treatment, on the other hand, looking at covert sensitization. All right, this is a behavioral therapy. We are done with the biological, now the psychological. This is a behavioral therapy based on classical conditioning. All right, so they try to use classical conditioning to treat the participant. Now, what they do is they paired undesirable behavior with an unpleasant stimuli. Okay, now the undesirable behavior, for example, can be the stealing. Now you pair stealing with an unpleasant stimuli or stimulus rather. All right, let's say for example, vomit. Okay, or maybe observing or looking at something very irritable. Now you paired it with the behavior that you want the person to stop, right? E.g., nausea or anxiety provoking images to create a negative association. So, which is classical conditioning. All right. Now, the study by Glover, case study, what they did is they used a particular participant, 51 years old, with 14-year history of daily shoplifting, which is kleptomania. Right. So the woman has been stealing for 14 years and she's now 56 years old. Right. You can see that. Now, shoplifting began after her husband's conviction for embezzlement. So it led to isolation for her. She had low self-esteem and depression. So eventually she started stealing, which is kleptomania. And then she was stealing not because she needed a thing. All right. She was just stealing. There was a situation, a case where she stole a baby shoe and she had no baby, right? So what is she going to do with the shoe? Nothing. Okay, so treatment procedure, first session at 2 weeks interval. All right. So each session had 2 weeks interval. They had a total of 4 sessions. All right. She was treated muscle relaxation, all right, technique to enhance visualization. So she needs to be able to relax herself so that she'll be able to visualize properly. Okay. The patient was guided to vividly imagine, not with headgear, please. It's just a picture. All right. To vividly imagine feeling of nausea and vomiting. All right. So imagine the feeling. She was guided in a particular structured way such that she'll be able to imagine it effectively. All right. The feeling of nausea and vomiting while envisioning the act of stealing. So she's combining this kleptomania behavior with that feeling of nausea and vomiting in her mind. Right now, along with anticipated disgust from onlookers. So she's able to think of vomit when, for example, stealing. And then what does she think people will think around? Oh, the disgust people are going to see. Okay, yeah. So she was able to pair that with the behavior. So she was trained to do that. Okay, that was the therapy. That was what the therapy was about. Training her how to be able to pair those two things together. And then she was taught muscle relaxation as well. Now, in the final session, she visualized the unpleasant sensation dissipating as she replaced the stolen item. So during the final session, she was able to imagine that, okay, yeah, the dissatisfaction she was feeling when she was imagining the situation now, it reduced when she dropped the stolen item. The stolen item still is in her imagination, not in reality. Okay. So what was the outcome? Follow-up result at a 9-month follow-up, she reported a significant decrease in the urge to steal. So when she was trained to do that, all right, she reduced her urge to steal. In reality, she stopped stealing. Okay. So, and over the past 19 months, which is 1.5 years, she only had one relapse. She only went back into it just once. Okay. An improvement in self-esteem and social functioning. So she was able to improve generally. So psychological treatment, imaginary desensitization, a cognitive overview of, okay, yeah, this is another one. All right. aside the covert sensitization, all right, the second one is imaginal desensitization. This is a cognitive behavioral therapy that employs guided imagery and relaxation technique. All right, this is different, although to some extent it's kind of similar, but it's very different. Covert sensitization, do not forget, it relies on classical conditioning where you paired the behavior you want to change with something that unpleasant stimulus, okay, something that you do not like. Okay, now this one on the other hand, you're able to imagine. Clients are taught progressive muscle relaxation as well, and then asked to visualize situations that trigger their impulse behavior. So you think about, okay, the situation that actually triggers the urge. Now, the goal is to reduce the emotional and physiological arousal associated with this trigger. Now, physiological arousal is basically, okay, let me say one way to experience emotion is you have the physiological arousal, talking about your heartbeat increases. So you have the faster heartbeat, and then on that ground can emotion happen. Okay, if you're able to control your heartbeat now, okay, you're able to control your body arousal now, emotion is going to be less. Go and check yourself. Each time you feel surprised, you have high heartbeat. Each time you feel happy, extremely happy, you have high heartbeat. Each time you feel fear, you have high heartbeat. A lot of emotions, there is this high heartbeat. So if you're able to reduce your heartbeat, which is also through muscle relaxation, okay, then you will be able to reduce the arousal, okay, and which in turn reduce the emotion that trigger that. So as you're imagining the thing that actually make you want to steal, make you want to gamble, make you want to set fire, then you are now trying to relax yourself. Okay, calm down, relax yourself, relax your muscle, so that way you're able to control your emotion and reduce the urge. Okay, example study done by, this name is a little hard to pronounce, Blagzinski. Okay, yeah, and Noah, 2003. The therapist instructs the client, a gambler, to imagine a stressful situation. Okay, stressful situation, talking about an environment where they are to gamble. Okay, followed by the urge to gamble. The client is then guided to mentally step away from the urge. Okay, leveraging on the muscle relaxation technique while remaining in the relaxed state. You see, sessions are often audio recorded for practice outside therapy. So they record the session so that the person can practice even after. Now, is it effective? Yes. Studies has shown that. Studies have shown that significant reduction in arousal and anxiety associated with gambling impulses. Okay, significant reduction, yeah, in arousal and then the anxiety, the urge, which is associated with gambling impulses. Clients report enhanced control over their impulse with effect lasting up to 5 years post-treatment. So this is very good, right? It has a long-lasting effect. Now, research method and evaluation of psychological treatment. Now, what is the strength? They used basically case studies, right? And control trials. So the trials were controlled, which provide in-depth qualitative and quantitative data, right? Do not forget they also used some form of measurement to be able to determine, okay, if they are improving or not. Okay, now they also use standardized technique, for example the progressive muscle relaxation, all right, and follow-up assessment to gauge long-term efficacy. So that is good, right? Limitation, however, it's a case study. For example, the Glover, all right, studying the woman, right, with 14 years of kleptomania experience. Now you cannot generalize this result to all individuals with ICD, right? Because the woman's situation is different. Therapist bias and small sample size can affect the reliability and validity of this finding, right? Yeah. Integration and overall consideration. Combination approach. Yeah. Biological, which is drug, and psychological cognitive behavior therapy can be used in conjunction to manage ICD, particularly in treatment resistant cases. So you can combine them. All right, nature and nurture debate. Biological treatment targets internal factor, the brain chemistry. okay, which is nature, right? While psychological treatment address learned behavior, okay, how you be able to unlearn what you've learned, all right, looking at and cognitive distortion, for example, um, the classical conditioning, all right, you're trying to use something to unlearn that behavior, right? Or let me say you're trying to learn a new behavior by pairing two things, making gambling look disgusting. You're trying to learn that, okay? So, an interactionist approach may suggest that both inherited vulnerability and environmental trigger contribute to impulse control disorder. Now, application to everyday life, understanding individual predictors, for example, family history of alcoholism, which can help us predict how someone responds to opiates. Okay, severity of gambling urge, okay, can help clinicians tailor treatment plan for better outcome, right? So if you have all those things, which can be individual or it can also be according to nature, if they have genes that if they have this thing to have altered their gene in their family, they take alcohol, so there could be a part of their gene that is already affected. So if you have someone with such experience now, it can inform you to know that such a person will relate, or let me say will react positively to the opiate. Okay, yeah, effective management can reduce the social, familiar, and occupational impact of ICD, right? Okay, yeah, so that is it. Thank you. Yeah, so that is it. Thank you very much. Please, if you have learned one or two things, try to subscribe to my channel. Please subscribe, like my videos, okay? And you can also stay tuned for more. All right. Thank you very much. See you next time.